It's a special honor to be here and to have opportunity to share my experience over the last 25 years in myeloproliferative neoplasm area, which is just a testament of how the field is evolving, and I only feel privileged to work with so many colleagues in the field, like Claire here and others that were participating today, to lead the development of new drugs that now you know about, some approved, some soon to be approved, to improve the quality of life and longevity of our patients with myelofibrosis in particular, but also ET and PV. And I would have felt much better if Claire was saying, here we have a retiree who knows something about MPN. He will give us a talk rather than everything that you said, because I actually officially retired from MD Anderson. From MD Anderson. I started at MD Anderson last century, so you know how old I am. And regarding the questions, I like the interaction like this a lot. And in fact, my first talk ever was in 2005, when I was a baby in MPN 18 years ago, to the patients. And that was Patient Symposium, which is every other year in Scottsdale in Arizona. And I was assistant professor that time, only a few years in the leukemia department at MD Anderson, and focused since early 2005 on MPN specifically. So to make it interactive, and understanding that my English is terrible and accent from Texas, where I live since last century, influence what I say, I like you to ask me questions as we go through the slides, okay? Because I would like you, I'll make it simple as I can, so that we have real interactions here, and I learn from your questions where are the areas where I need to improve, or we as a group, as a doctors, we need to improve. So 2005, I started my talk with what was considered to be the top of the line understanding of the biology of myelofibrosis and MPN. And I remember the patients that were like you looking at me, they say, oh my God, this is so complicated. And I really don't want to go away from that, because what transpired over the years will bring us back, as you will see, to the problems that we have. Here it says megakaryocytes. Here it says monocytes, histiocytes. We were able, under the microscope, to see what cells are wrong. They're not normal. We were able to see these black lines here. These are fibrocytes, or fibers in the bone marrow, fibrosis. We were able to see under the microscope all these brown lines. These are new blood vessels that are made in the bone marrow to sustain the growth of malignancy. And we were able to see abnormalities in bone structure. All this has fancy names. This is called osteosclerosis, neoangiogenesis, and so on. But fibers, blood vessels, abnormalities in bone structure, bone hardness, were something that we were able to see. And we explain all these abnormalities by these funny names here. What is this? All of these are proteins that are secreted from those cells in the blood or in the bone marrow. We call them cytokines that make a chaos in the bone marrow and make this all happen together. We call this cytokine storm. A lot of cells which are abnormal produces a lot of different proteins. This is how we were explaining myelofibrosis at the time. And we should be directing our therapies to prevent the fibers, or to prevent the blood vessels being made, or target each of these individual proteins in blood that possibly drive the fibers or the blood vessels, or affect the bone structure. This is where we were in 2005. And we did tons of studies with blood vessel medications, antifibrotic medications, anti-TGF-beta cytokine, and so on. And then you know that in that same year, just a few months later, there was a discovery of what is in a title, activated JAK-STAT signaling. And I always like to say simply what that means is that in the normal state in the body, and this purple being the cell, on the surface of the cell you have these blue structures here. These are proteins that go through the membrane of the cell. These are called receptors. These cytokines that I talk about are represented by this circle, purple circle. Cytokines go around the blood. They would attach to the receptor on the surface of the cell, activate the JAK2. The JAK2 would activate the STAT, JAK-STAT pathway, and that would make cell do something. That's a signaling pathway around our body. This particular signaling pathway, JAK-STAT pathway, is important for blood making, makes cells grow. It's important for inflammation, body becomes inflamed, and it's important for immunological activity, immune function, inflammation, and blood making. That's normal function. And this JAK-STAT pathway gets activated only when there is the binding of the cytokine to the receptor, not all the time. So I am in a car accident. I bleed a lot. My body will sense that I am losing blood. My body will make a lot of this purple cytokine. We call it growth factor, which will go to the bone marrow, attach to the bone marrow cells on the receptor, activate the JAK-STAT pathway, and I will make blood. That's normal function. And then in 2005, in the spring, there was a discovery of genetic abnormality, as you all know, in the gene that actually makes this JAK2 protein. So you have a mutation here. The mutation makes this JAK-STAT pathway active all the time. You don't need anything to bind to the receptor anymore. You have continuous activation, and the cells are made all the time. When I describe this to my patients, they say, you mean highway? It's a highway now, it's not a pathway, because it's active all the time. And after the discovery of the JAK2 mutation, you had the discovery of a mutation in the gene that makes the receptor itself, one of the receptors, that's in red color here. And eventually also the discovery of the mutation in a gene that makes a protein called calreticulin, or CALR, which is exported outside the cell and binds to the receptor. Binds to the receptor and makes this JAK-STAT pathway always active. That's why we call the JAK mutation, MPL mutation, and calreticulin mutation driver mutations. They drive that highway all the time. And when we had the JAK2 mutation identified, we said we're going to develop the JAK2 mutation-specific medication. And now you know that we did not develop that so far. We don't have a JAK2 mutation medication produced by any company at all these years. What we do have, we have a JAK inhibitors. The JAK2 inhibitors will be inhibiting this one, and this one, and this one, and the normal one. They're not specific at all. You don't really need to know whether myelofibrosis patient has a JAK2 mutation, calreticulin mutation, or MPL mutation. As long as there is a verifiable diagnosis, patient has an indication for therapy, the JAK inhibitors will help by inhibiting the JAK-STAT pathway. It's not specific for the mutation. But because it inhibits the normal function, it will cause anemia and thrombocytopenia. If I take a JAK inhibitor at the high dose, I'll be anemic and thrombocytopenic. Please ask me any questions. How is my English going? I mean, it may be rudimentary for some, but I understand that there are some that are new and may be useful. So just tell me, we know all of this. Go on. All right, what are then the JAK inhibitors for? What are they for? They're not going to eliminate disease, right? Because you push the dose to eliminate possibly the mutated cells, you will become anemic and thrombocytopenic. So what we do, we measure the benefits by looking at the spleen, and we look at the symptoms: night sweating, low-grade fevers, itching, bone aches and pains, fatigue. We can measure those by questionnaire, with a questionnaire. And how do you then, what do? You use an MRI, and you measure the volume, and after 6 months of therapy, you look at the benefit, and everything going down from 0 is at the beginning, everything going down is improvement, 20%, 40%, 60% better than at the beginning. Almost everybody has a benefit, to different degree. I would like everybody to have it 100%. That's the problem. We want to know why this happens, and that's why we have many studies where we combine with ruxolitinib. And by the way, this is the control, right? The control was mostly hydroxyurea or hydroxycarbamide. That's why when I'm asked, which one do you use first? No question about it. JAK inhibitor first. Hydroxyurea is usually perhaps combination to JAK inhibitors in case the spleen does not respond very well, but not as a first choice. So we have to dose the JAK inhibitors based on the platelet numbers because it can possibly control the platelets. That's why I talk usually about early intervention. The trick for me is presence of the symptoms. If the symptoms are present, that's the time to start therapy. And that is usually earlier in the life of the patients with the better blood cell count, so you can easier deliver the ruxolitinib, less of modifications or interruptions. And at the end, what we discovered is that it actually, without eliminating the disease, it can make people live longer. That's the same person, and we age together, as you can see. Yeah, I didn't want to show my picture in 2008. Right, but this particular gentleman came in a wheelchair. You can see that, right, with a cane. He lost about 35 kilos, unable to walk. The same happened with this gentleman here. He was not able to walk. He was lost all the weight. You see that he gained weight? You see the ribs here? You don't see the ribs. Sometimes patients do get too much weight. I heard that earlier today, right? And then they come to the office and say, I have backache and a belly pain. I say, well, it's not from big spleen. You need to change your chocolate to broccoli and do the exercise. All right, so life can actually be longer. How much longer? If you have 100 patients, you would say average 2 to 3 years on average, longer. But then again, early intervention matters, so earlier intervention possibly has more of a benefit on the longevity. Why not longer? Not longer because the disease is still there and it's complicated. Okay, we don't need to study this, all right? Anybody can point where the JAK-STAT pathway is? Anybody? No? Oh, gentlemen. Oh, yeah, right there, right? All right. What is all this about here? We learn that there is so much else wrong, which will direct where the disease goes, how the disease responds to therapy, who actually goes to develop acute leukemia, which is about 20% of the patients, who will do well for a long period of time, and we have these prognostic scoring systems in place. But the point here is all these white boxes is the type of the new therapy and the name of specific drug actually in that group of the new medication. So, for example, here it says BCL2, BCL-XL inhibitors, and navitoclax is the example of this class of drugs which is in clinical studies. So, why I'm showing this is first to show you complexity of how complex the biology of the disease is, and how we learn about it, and what are we doing about it. All of these drugs are in clinical studies. I'll just give you 2 examples of how biology leads us what to do. One is the BET inhibitor, BET. To the left, you have a cell from myeloproliferative neoplasm. You have the DNA here, and you see here a BET. That's one of the proteins that controls the genetic expression. And that is not normal, right? This is the cancer cells, malignant cells. They make all these abnormalities. Now you would remember that from the first slide. You have a fibrosis, you have cytokines, right? You have cells that are not normal, megakaryocytes, and so on. So if you would have an agent, as this one is, CPI-610 or BET inhibitor, that would control the genetic expression, that would then possibly lead to elimination of these cytokines and normalization of the growth of the cells in the bone marrow. That's obvious target for therapy then, and we have studies in very advanced setting for possible approval of this particular drug in combination with the JAK inhibitor, because the JAK inhibitor, ruxolitinib, is the backbone. It works for the spleen and symptoms, and everybody should be, if they have symptoms and the spleen, then given that for its value. This one is completely different. Look at the cartoon. Just to, again, give you a sense how the science leads us where to go. Here in green color is the DNA. At the end of DNA is this particular piece that we call telomere. With each division of the cell, you lose, or the cell loses a piece of DNA at the end. And that has to be repaired before the next division is, because if you lose too much of DNA, the cell dies off. And so this is DNA again, here in blue. And this here is the enzyme, which is called telomerase, that maintains the ends of the chromosomes by building it up as the cells divide. So this drug, which is called imetelstat, inhibits the telomerase, and the cells die off. So that's another drug as an example how the science leads us in the development of drug. And this drug is also in the phase 3 randomized study for possible approval in patients who are resistant or refractory to a JAK inhibitor, and it's compared to best available therapy for prolongation of life, in fact. Any questions so far? Yes, please. I can repeat the question.
So the question is, you talked about the spleen and
Yes.
quite often.
Yes.
What impact does it have if you don't have a spleen to start with and it's not been removed for treatment for any of these conditions? No, a splenectomy. They've had a splenectomy.
No spleen, but you have symptoms from myelofibrosis or symptoms from myeloproliferative neoplasms.
Well, this has been, the spleen was taken, I'm talking on my husband's behalf here. He doesn't know I was going to ask the question. So, spleen was removed when he was a teenager.
Sure.
And when this started, they were doing ultrasounds to see, because he had spleen pain, although he didn't have one.
Okay, I can't really explain that just like that, right?
But my question was more, does it have an impact if you don't have a spleen?
No, actually, that's a really good question. Thank you for that. So there are patients that had a splenectomy as a therapeutic approach. I'm sorry you had your spleen removed for some other reason. But we actually had the patients that didn't have a spleen but had a big liver. What happens when you remove the spleen? The next in line is the liver. And so we published that, and the liver becomes smaller. Not as fast as the spleen. Spleen, in 2-3 months, you get what you get. And in terms of quality of life improvement, you get everything within a month or two. You just have to have a good dose, right, which is safe to give. That's the key. And why the spleen goes fast? Because it's a blood organ. That's what we explain kind of in shrinks. Although you are not killing any cells, they just stop growing. The liver is more of infiltration of the blood cells into the tissue, and that takes more time. Now, would I treat the patients that do not have a spleen or a liver and have a bad quality of life from the myelofibrosis? Yes, because the indications for therapy of signs or symptoms. Sign would be the big spleen, and the symptoms are symptoms. So I know that in the UK or other countries around the globe, there are different regulatory, mandatory objective measures that need to be fulfilled for drug to be prescribed, but in my own practice in the United States, if the symptoms are from myelofibrosis, you would treat the symptoms, right? Any other questions? Excellent. Yeah, don't be shy, that's fine. Okay, let's move on. So, what happens when you stop ruxolitinib? This is not a nice slide. It doesn't really provide a good outcome. So that's why many studies are done to combine ruxolitinib with something else, other investigational agent, either from the very beginning or when the patients are not doing very well. We call it suboptimal response patients or patients that are losing response, because that usually takes time. It's not overnight. You wake up in the morning and it doesn't work anymore, right? The spleen slowly goes back, or symptoms slowly come back, or anemia develops slowly and you need to decrease the ruxolitinib by guidelines, and then lower dose doesn't work as well. Because after ruxolitinib, unfortunately, life expectancy, because of lack of other active agents, is not very good. So, and there are, of course, findings that say who will do better than the others. So low platelets, that bad prognostic factor, or additional genetic abnormalities that we learn a lot about today are bad prognostic factor for the longevity of the patients after ruxolitinib. And that's why I say, have a plan before you start ruxolitinib. Optimize it by adding something to it if you can. If the anemia is a problem, possibly anemia drug if possible. If you have a big spleen still, or it's coming back, maybe hydroxyurea on top. Depends, how is this possible in the environment where you are? And then consider definitely clinical trials. And this, I love this slide from Italy, from Dr. Palandri, good friend in Italy, where she looked at the patients that discontinued ruxolitinib. It says months from ruxolitinib discontinuation. And unfortunately, this is survival. You see the difference between the two curves. This one is patients that participated in clinical trials. And you will tell me it's not fair, because these were patients that were fit for clinical studies, and the other ones did not go in the trials because they were not fit. I understand that. Certainly, this is not a randomized study between the two groups of equally characterized patients, but just as a finding, it's very, very reassuring to me that we are trying very hard and we have some successes, even with the trials that are with medications that are not approved. That's why I encourage everybody to look for a clinical study, even from the very beginning, if there is a trial where you combine novel agents with ruxolitinib from the day one, even if it's a placebo-controlled randomized study, because we want to make together a difference for the future patients. And that's the testament to this. Okay, there is research in the other areas, not just myelofibrosis. This was mentioned earlier on. Claire explained this. I love this slide because it also addresses the biology of the polycythemia vera. Here we have a cell, it's called macrophage. These are cells in the lining of the gut or a liver that would be storing the iron as you ingest the iron. What happens here, through this tunnel here, the iron, which is this particular orange circle, is excreted from the cell and picked up and carried around the body until it comes to the bone marrow, where they utilize the iron, the bone marrow utilizes the iron to make red blood cells. That's a polycythemia vera. So the medication that is called PTG-300 mimics the protein. Here it's a very low hepcidin. Hepcidin is the regulator of iron trafficking, let's put it that way. And it's very low in PV. If you give it artificially, hepcidin mimetic would give a lot of hepcidin to a patient with PV, you shut down this tunnel and there is no iron anymore for the bone marrow to make red blood cells. And what happens when you don't have iron to make red blood cells? The red blood cells decrease, right? And your hematocrit goes down. And that's what happened in the studies. These are patients that were on phlebotomy only. Here is the before rusfertide, that's the name of the medications, how often they were phlebotomized, and on therapy, hardly anybody. Immediately, within 2 weeks, 9 out of 10 patients eliminate need for phlebotomy because the iron is not available for blood making anymore. And this is in patients who were on hydroxyurea or ruxolitinib or interferon and still needed phlebotomy and, to this extent, and it goes away. So this drug is in phase 3 randomized study for possible approval for patients with PV that need too many phlebotomies. They have their own definition of what is too many. We can argue about this. That was the question earlier today. It's not uniformly acceptable, but very interesting how the science leads us to develop new medications. And of course, that leads us to discussion, what is the disease modification that we are looking at? Is this the elimination of the fibers in the bone marrow? Is this the decrease of the allele burden that we have been talking about all along? Is this the elimination of cytokines, those proteins that I talk about? What does it mean when we talk about new therapies, biologically driven medications, having an influence on disease? Disease modification in myelofibrosis in particular is a very hot topic. These are more recent papers. I'll give you a couple of examples. This is with a medication which is called naftemadlin, and this is in a study in people who are relapsed or refractory to ruxolitinib. So single agent naftemadlin is given alone. People who don't have any benefit from ruxolitinib anymore, they are given this in a phase 2 study. Everybody gets the therapy, the same dose, no placebo, nothing, phase 2 study. So here it says that the patient who normalized the blood CD34 cells have a much better progression-free survival. That means they do not progress, and they have better overall survival. They will live longer. So you would say, what is this, CD34 cells? These are cells in blood, like a progenitor's baby cells, that you can actually measure. But that doesn't mean that we need to do this in everyday practice. That's just an example where one of the biological parameters made these people, for some reason or the other, live longer if these cells are normalized. The other example has been shown many times today, the JAK2 molecular response, right? Measuring the number of the cells in a blood or a bone marrow of a patient and see whether they are decreasing and whether this decrease of the JAK2 positive cells, allele burden, affects the outcome of the patients. And this study is from Italy, actually. The decrease of the allele burden, complete molecular response or deep molecular response, hardly any detectable JAK2, prevented any patients to progress. Partial molecular response, this is the definition for that, is here, and this is no molecular response. Do we need to measure the allele burden in every patient? No. This is part of the clinical study, so that does not reflect this way in another study. There is no uniformity to this. We are looking for biological parameters that would be uniformly acceptable and verifiable in all these studies so that we can, with certainty, say that marker needs to be measured for certain clinical benefit. That does not exist yet. We are still bound to look at the spleen size, for example, or in a PV or ET, normalization of the blood cell count and prevention of thrombosis. This is all academical research and not ready for everyday use. And then what was shown before, and I just want to highlight this because we are opening new chapters in development of new drugs, is specific targeting of the malignant cells. And that was highlighted earlier on. This calreticulin protein, mutated one, is produced in the cells and then excreted outside the cells, and it's bound to the receptor. So the immune system can see it, right? You heard about this today. Immune system can see this and recognize it as something abnormal. It's a marker for malignant cells because it's on the surface. Somebody asked about the JAK2 mutation. That's inside. Immune system does not see it very well. This one is outside. So you can develop antibody. What is the antibody? Here is the cartoon. This is the same depiction. This is the receptor. This is a mutated calreticulin here, which is produced inside the cells, goes outside the cells, binds here, and makes this JAK-STAT pathway active all the time. There is this antibody that is depicted here that binds to the mutated calreticulin and prevents that signaling. So that would be specific therapy targeted for malignant cells, only malignant cells in patients with calreticulin mutation, about 30% of the patients with myelofibrosis. And as it was shown before, now we do the full circle. Remember, I showed you the first slide, megakaryocytes, abnormal megakaryocytes. This was shown before. Hardly any left. So you normalize the bone marrow and say, hey, this has a biological activity, which should then be seen in a clinical study. Clinical study is soon to open. The vaccinations were highlighted as well. The first such a study, vaccinating the people against calreticulin so that the immune system, the T cells, so-called T cells, would recognize those malignant cells, was done in Denmark. There was induction of the immune response. You could see in the blood of the patients that there are many T cells and they should be doing something. Unfortunately, there was no clinical response. There was no change in the blood cell count or anything else. So work to be done. And just as an example how cumbersome this actually is, I show you this slide. That's a clinical study in New York at Mount Sinai Hospital, their own vaccine that would boost anti-tumor, anti-calreticulin T-cell responses in patients with calreticulin mutation. And not to go through the details, but just give you a sense, how is this done? These are weeks. All of these here are injections of the vaccine. This one here is a booster, so the immune system can recognize the vaccine. It's a cumbersome process. It's not that easy. It's not like a flu shot. You go for a flu shot, and next year you go for another one, perhaps. This is completely different. It requires attention and commitment, but it's worth doing it, because imagine that we can be vaccinated for those that have a little bit of calreticulin in blood and normal blood cell count to prevent progression to overt myeloproliferative neoplasm. And finally, something completely out of the blue, umbilical cord blood. All right, so this is really a very small company that collects, look at this cartoon at the top. Umbilical cord blood are usually discarded, right? It can be collected. In that blood, you have a lot of different cells. And you have these T cells, again, we call them T regulatory cells, or Tregs, that are immunologically naive. They come from the naive baby, right? Doesn't have an immune system that would recognize anything. So they can be actually given to a patient with the idea that will work against the malignant cells. So these cells are collected. They're actually then put in a laboratory in a dish, exposed to certain factors that would make them go to the bone marrow of the patient, and possibly then alter the bone marrow and decrease the malignant clone. This is depicted here, multiple doses and multiple injections once a month. Cord blood, really completely new chapter. We call this cellular therapy, right? Cells are given to patients with myeloproliferative neoplasms, not specifically targeting anything on the surface of the cells like the antibodies, but this is opening a new chapter again for a new drug development. So in summary, a lot is happening here in myeloproliferative neoplasms, as you can see. I encourage everybody to go on the clinical studies. They're driven by excellent science. There is always a good justification why something would be done. And the correlative studies that, as I showed you a few examples, do suggest a change in the biology of the disease. So confirming the hypothesis, basically. So I thank you very much for your attention.